Thank you very much. I'm very pleased to be here. I'll tell you just a little bit more about myself. I am a pediatrician first. I subspecialized in what's called neonatal perinatal medicine. So I work in the newborn intensive care unit. I've worked there for 30 years at Riley Hospital. So most of the patients I take care of are about this big. And I spend most of my time talking to the parents. My patients and I, we communicate, but it's not with words. It's more with touch and just being there. So this is a little bit different for me. So I've tried to think about what we could talk about that you might find interesting and new. So I'm going to start off beginning from sort of a doctor's perspective and why it is so hard for us to talk about giving bad news or end-of-life issues. So that might give you a peek behind the curtain, as someone told me already. And then I'm going to talk a little bit about what we have learned that patients would like to know from a doctor when they have to hear bad news. And there actually are recommendations for doctors about what to talk about and how to talk about giving bad news to patients. So that's sort of the material I'm going to go over first. And then we have a couple of role-playing things that I'd like to do just to show you how a physician can speak with a patient who doesn't want to know what's going on and one who does want to know what's going on, and just show you the difference and how hopefully the physician picks up on that. So we'll get started. So, this is going to start out pretty simple. What do physicians actually do? Well, they examine patients, they take medical histories, they prescribe medications, they order, perform, and interpret tests. They help patients overcome their illnesses. That's what doctors do, And this is a lot of what we do. But we also, consult patients on diet, hygiene, and preventative health care, and we strive to keep patients healthy. We hope that we do this more than we do that, but it sort of depends what kind of doctor you are, which you do more of. Of course, all my patients are sick because they're all babies. If you work in a newborn, or if you work in any intensive care setting, this is going to be where you're focusing. So this sort of depends on what kind of doctor you are. Some physicians are surgeons, and I think we have an idea what they do. They operate on patients to treat injuries. They take out bad things like cancerous tumors, and they work to try to repair physical defects. Again, this is mostly in children. The one thing all of these different kinds of physicians have in store is that in order to provide the best health care, physicians must be confident that they're competent. Physicians are driven by an attitude, I can fix this. I can help this patient. And who wants to go to a physician where you sit down with them and they say, oh, I don't have any idea what this is. And I don't have any idea what to do for you. And I don't know who to send you to. That's not a lot of help. So, we want to go to people who want to help us get better. But this is a difficult issue because sometimes when presented with an unfixable problem, physicians find themselves not very well prepared to help the patient further. What do you do when you know that the problem you're seeing is not fixable? Well, that's a difficult position. So why physicians do not have discussions about poor prognosis? I'm going to give you some insights. And actually, a lot of them are misconceptions on the part of the doctors about how their patients may deal with hearing bad news. So these are some things we actually sort of propagate among ourselves that we need to actually deal with. So we're afraid if we give you bad news, you're going to be depressed. And you very well may be. But actually, it turns out, if you study this problem, that's actually an incorrect misconception. Providing honest information that'll allow the patient and their caregivers to better cope with the illness is what one needs to do. We think, well, if I tell them what's going on, they're not going to have any hope. I just can't do that. Well, that's also incorrect. Hope can be maintained even after a truthful discussion in which you share with the patient that there is no hope for a cure. That doesn't actually completely remove all hope. And we'll talk about that towards the end, because that seems kind of amazing that that could be true. Physicians also think, well, you know, if we get hospice or palliative care involved too soon, the patient's just going to give up. It's actually going to hurt their chances of survival. Well, it turns out that's not true. If you get palliative care or hospice care involved early in a patient's treatment where you know they have a serious, potentially life-threatening chronic illness, they actually do as well or better than patients in which you do not do that. So that's a bit of a misconception. Well, we say, well, I can't really tell them what's going on because I really don't know how they're going to do. I don't know what their prognosis is. Actually, often that's true, because for any individual given patient, you really don't know exactly what their outcome is going to be when you're sitting down with them and you're talking about their illness. But that's with qualifications. You do know what the last 5,000 patients that have had this disease, what their data are. So if you know that a patient has a particular disorder, there's information about how patients do with the treatments that are currently available for that disorder. So you know that information. It's just that you don't know where the patient's going to fit. Are they going to do better than most? Are they going to do worse than most? And so this is what often keeps your doctor from really wanting to share with you specific information about your diagnosis, because actually, technically, they don't really know for sure what's going to happen to you. Some decline to talk about it because it's not culturally appropriate. There actually are some cultures where they don't really want to talk about exactly what's going on. In fact, there's some cultures in this country where 75% of the people asked said they don't really want to know what's going on. And that's just the opposite for other cultures where almost 90% want to know what's going on. So you have to, again, know your patient, know something about them, and as we'll see later on, you need to talk to them about what they do and don't want to know. So while there are cultural differences in how people want to hear bad news, you just need to ask them how they want to hear that news, because you can't guess just based upon cultural differences. Some physicians don't want to talk about this because it's hard. Well, that may be true, but we owe it to our patients to talk about these things because the vast majority want to know what's going on. So it is hard. I mean, in the newborn intensive care unit, we lose about 6 babies a month. And I've been doing that for 30 years. Well, that's a lot of difficult talks. Now, we also have hundreds of babies that we have great outcomes every month. So it's much better weighed towards good news than it is bad news. But the fact of the matter is, life and death are two things that are all about what we all must deal with in our lives. Well, I'm afraid if I give them bad news, they're not going to be satisfied with my care. Some physicians. Actually, that's true. Patients tend to be more satisfied with those physicians who only give them good news or avoid giving them a poor prognosis. It's actually documented. But this doesn't mean that that's the most optimal care. And in fact, there is data to suggest that is less than standard care. If you're not telling something that someone really ought to know so they can help actually truthfully plan about what's happening to them, that's really a disingenuous thing to do. So, but it is interesting the way, and I'm being transparent here, the way physicians are now paid. We're paid in part depending upon whether our patients like us. We actually have to depend upon satisfaction surveys. And how many of you have gone in for some kind of health care and 2 weeks later you got something in the mail where someone wanted you to fill out a satisfaction survey with the experiments? I mean, how many people have, and did you fill it out? Yeah. Yeah. Actually, usually only about 11% of those things come back. But you're actually paid depending upon how many of your patients return those things and how they've scored. It goes into your paycheck. And it's sort of like, really? But it's like, when I go to get my car worked on, I get the same thing. But before I leave, the person tells me, now look, you have to give me 10s. If you can't give me a 10, just tell me what I have to do to get a 10, because you have to fill out the survey and you have to give me a 10. And so I'm so tempted to say, well, just give it to me for free. I'll give you a 10. But physicians can't tell you that. They can't tell you, hey, I hope you had a good appointment today because I really need your support to fill out that satisfaction survey. But it is, it's something you should know. Why does discussing prognosis matter? Well, failing to do so, not discussing it, patients lose quality time with their family members. They lose time to reflect and to prepare for death. It may prolong their time in the hospital, which is hard to do these days because they're really trying to move you out. And it really diminishes both your and your caregiver's options for your care. So it is an important thing that we need to do. But these are just some of the misconceptions, some of the things behind physicians. But some of this is because we think we can fix it. That's what we do. That's what we try to do. We try to solve every problem that we're faced with. And I think we have a hard time when we know we can't fix that. So I'm just going to share one. I'm not going to talk much about myself today, but this is one thing I'm going to share it with, because I learned this 30 years ago. And that is, I know there's a God, and I'm not him. And I don't make anybody well. No doctor has the power to force anyone to become well. What doctors do is we try to understand the illness and try to give medications if they're available or surgeries if they're needed to try to help you get well. But it's up to your body to get well. There's not a treatment that exists that will make you well. And I don't think most people understand that about doctors. You go to doctors so that they make you well, but no doctor has that power. And I think as a Christian, you come to grips with that because I had a very hard time losing patients early in life because I felt like that was, my fault. I let them down. I should have been able to make them well, and then I had to understand, actually, I never can make anyone well. I have to do the best I can to give them the most state-of-the-art care. I have to be innovative. I have to think of new things. I have to think of different ways. But in fact, if we do everything we possibly can for a patient, they may still die. And that's out of our hands. So it's just one other little piece to fit into this. Some physicians don't feel that way. Particularly surgeons. And I think it's hard for surgeons because can you imagine the amount of courage it must take to open up someone and take something out? I mean, who do you think you are? Right? I mean, it takes an awful lot of experience and practice and courage to be able to do something like that, particularly if you're not putting anything in. So I think every physician that you'll encounter will have dealt with this a slightly different way, and some you can tell believe they can heal every single patient, that they actually can do it. And then there'll be others that are a little more introspective, and like myself I'm probably on the other side, where I understand what I can and cannot do. I try to share that with my patients. I try to help them understand that complexity. All right. What do patients want to know when they have to hear bad news? So this is research that I'm presenting. So they want to have the discussion in a quiet, private place. They want to receive the information from a physician who communicates clearly with them. They want the physician's full attention. They don't want them running in and out, answering their pager, listening, doing a phone, checking their phone. They want the full attention. They want to have time to ask questions. They really want to know how this is going to affect their life. They would like to have other people involved or not. Some may choose not to. Some may choose to have family members sit in and receive the news, and they'll get it from the family member. So you can have all different kinds of varieties of that. They want to be able to express their emotions. This is something Jim spent some time with on the very first session. They want to make sure that once you give them this news, you're not going to abandon them. This is a difficult one because, again, if you're going somewhere to receive certain kind of care, and you've had that care, and now that care is no longer working, and they have no more care, and they sit down and they tell you that, then sometimes they don't make any more appointments. And then you sort of feel like, well, okay, now what do I do? And you heard a little bit about that at the last talk about palliative care and how hopefully people make a transition there when you reach that kind of difficult discussion. And you want to feel like the physician hears your fears and any preferences that exist. So there are clear recommendations that are published on how we talk about this with patients, and these are mostly compiled from experiential kinds of things, although some of them have been validated, so they've tried different ways to break bad news to patients, and they've found things that work and things that don't work. So I'm going to go over just some of those. to give you an idea what you can expect that you should be able to bring up with your doctor, because these are things your doctor should know about how to break this bad news. So, as always, this is really important. You have to know your patient, as I said earlier. If they're coming to you and they've been coming to you for 20 years, you'll know them, But if you're referred somewhere because your doctor knows that you have something, it's not something good, and you need to go somewhere to figure out exactly what it is and how to receive treatment, you have to hustle pretty quickly to get to know your patient so that you can sit down and talk about the illness and the prognosis. You really need to know this. If, your family, your patient, your family will have a Google-based knowledge about what's going on, and you better know what that is. You literally, we actually do that. We go on and see what's online because it is amazing what's online. And people think it's true. Of course, because it's online. It's got to be true if it's online, right? I mean, somebody checks that stuff, I guess. But you may spend the whole first time debunking a Google problem. So you need to know the other side of it then. So then you need to provide reading material. You need to provide evidence. You need to provide things that can be, discovered. So this may not be any good, but you can tell them where to go to get the information and then let them go get it and read it. You need to ensure that it is private and that there's adequate seating for whoever is going to attend. You need to turn off your cell phone as a doctor. You need to prevent interruptions and allot adequate time to have a discussion with your patients. You would hope that this would be something we would be doing every time. And, again, identify family members or caregivers that really should be present to have this kind of talk. The first thing then you need to know once you get to know the patient is really what do they know? What do they understand? This is really, really key. Most are aware of the seriousness of their issue. Remember, we're talking here about patients who you're going to be giving bad news to. So most of them are going to have some serious illness, and they'll probably have some idea that it's that. You need to explore how they feel about that. Who are they talking to about that? Have they talked to anybody about that? You need to identify potential conflicts between their beliefs and the diagnosis. And one of our case studies will actually go through this a little bit, just to give you a taste for what I'm talking about here. So it does actually sort of track with what I said before, which is kind of an interesting twist. But if you believe that God is the one in control, and God is the one who's going to decide how this all ends up, and I want this to be according to His will, and that's what you believe. You don't really know exactly how that's going to turn out. Your doctor doesn't know how that's going to turn out, but that could impact your diagnosis and your care. So you could say, well, look, it's up to him. So I don't really care what the diagnosis is, and I just decided I'm not going to do any treatment because it's in his hands. Well, that may or may not be what he wanted. we don't know that exactly, but you certainly need to talk through that. You need to talk through that with the family members. You need to talk through that with the person. You need to talk through that with someone from their church. What are they talking about here? Is this a faith healing thing? Is this a matter of, well, we just don't want any intervention because God's going to heal me, and I'm going to show everyone that's the way it is. So that kind of thing can come up, and you need to be able to deal with that. Then the important thing is, well, what do they want to know? And again, each person has the right to decline to receive information or to designate someone else to receive the information. Just as much as you want to tell them what the problem is, they don't have to. If they don't want to hear it, you can't hold them down and tell them that this is the way it is. So you have to find out, how do they want to hear the news? How do you want to talk about this? Then you're ready to share the information. So you need to deliver the message in a sensitive but a clear manner. This was another tough one I learned. When someone is dying, you have to be sure that you just say it. You can't say, well, they're slowly slipping away, or they're going to a better place. What, you're going to move them to a new, more expensive hospital? What do you exactly mean? You just need to come out and be clear, they are dying. And of course, once you say that word, then you probably have ended that session. Because once that word is heard, then there's quite an emotional release, and you need to work through that. But the point is, you need to learn to be clear in your message. You have to use simple language. Don't use jargon. Don't minimize the severity. Again, that just doesn't help. No matter how bad it hurts, no matter how much you like them, how well you know them, you have to tell the truth. Although that does feed into this one, you may tell the truth to someone else and they explain it the way it needs to be explained. And then you always need to go back and you sort of feed back, and you need to make sure what they understood. Really, so how are you going to tell your children, or how are you going to tell your husband or your wife, or how are you going to tell the church now about what we just talked about, and let them tell you what they heard? Sometimes it is amazingly off, and you need to go back over it again. Sometimes you go over it on multiple occasions before you hear them say it correctly, that, oh, okay, I got it, that's what you want. You must be responsive to their feelings. I mean, that's the whole idea in sharing this. You're sharing something that's going to affect their life. And always plan for the next step, even if it means no more treatment. Okay, now here's how we're going to help you. And that's where the hope thing comes in. So again, some of the things that patients prefer, if, let's say, you're making that step to hospice care now because there's no more treatment. This can be a confusing time because you just said there's nothing more that's available that we can do. And then they go on Google and they find that in Germany they're doing experimental treatment for your specific kind of illness, and they want to know if that's going to make a difference or not. And most of the time they need to understand experimental treatments, most of the time, depending on what kind of phase of study it is, they're not expected to change the outcome. They're just looking to see how to modulate the outcome. Patients prefer to have sort of permission and recognition of the team that they should, when you hear bad news like that, you're going to be sad. You're going to lose your family. You know there's going to be a loss of hope for the ultimate future in this life, and you're going to lose life as you knew it. And these are really big things that you have to help them with. And somehow you have to help them maintain hope through all of this. That's the hard part. So there's all kinds of hopes that people develop all at the same time as they're going through a complicated care. So I'm going to run through some of these. And in a way, I listed them in the transition that you normally see that happens. But there's rarely this smooth a transition as I'm going to present it. It can be from the beginning to the end, to the back again, and it can be very complicated. But of course, everybody hopes for a cure. That's the first thing when someone tells you bad news, you want to hear that, but I can fix this. We can fix this, okay? You want to live longer. You want to live longer like you've been living. Now, in some cases, if you've been ill for some time, you want to live longer better than you've been living, but you certainly want to live longer. You really want meaning in life, and it's often when you're coming towards an end-of-life kind of issue that you start to reflect on that. You really do want to be free from pain. We all want to be free from pain. We want and hope for a special time with our loved ones. We want to find a sense of completion, that, we made a difference. We want evidence that we contributed to others, that we had good friendships, that we have good friendships, that we made a difference in people's lives. Many people, not all, want to find spiritual fulfillment and peace with God. I mean, that's something I think all of us here are wanting to make sure we find every day. But particularly as you face an end-of-life issue, you're going to be thinking about this. And I think this came up at the very first session, I think when Jim was talking, that about looking at end-of-life issues, someone brought up the idea that they hope to have a peaceful death. So there's a lot of hopes that people are working through and developing, and sometimes they change sort of in this direction, they go sort of this way, and sometimes they jump all over the place, and this one will keep coming back and coming back and coming back. But, and sometimes people have this to the very end. They'll have a hope for a cure till the very end. And sometimes people never get to this point. That's a difficult one. What can physicians do to nurture hope in patients that are facing end of life? Well, again, being truthful, set realistic goals for the near future. This is what you can do. These are things that you will be able to do on a day-to-day basis. This is the care that's going to need to be required. This is the number of people that need to help. Defining what can be done. Importantly, pain and symptom support. Even if you can't cure this, we certainly can treat your pain. We can support you so that you can do the best that you can be doing. A lot of emotional and practical support for both the person and the caregiver. You want to have a dignified and safe place to be cared for. And many times that's not the hospital. It can be the hospital, but not always. You want a nurturing environment. You want to provide a sense of control for both the patient and their caregivers about how we do this. Given this information, how do we do this? You want to avoid prolongation of dying, and you want to help the patient find a sense of closure. So this actually sort of ends the informative part, where hopefully I gave you some views that were a little different, made you think a little bit differently about why doctors don't like to talk about this, but also why they also do like to talk about it. They just don't know how to talk about it with each patient. And so you really do need to feel free to talk to them and share with them how you feel about things. And so I set up a couple of, they're very short vignettes, but we'll start with the one where this is a patient who wants to learn about what's going on. I think that's, so Steve and I are going to be meeting here in the office, and Steve really wants to know what's going on, and this is how he and I are going to talk about this. So, would you like me to talk about the prognosis for this kind of cancer? And what kind of information do you want me to share with you today?
Well, I need to know how long I'm likely to live. I have plans.
Well, if you don't mind telling me, tell me something about those plans. I think it would help me to be able to give you information if I knew what it was you were planning to do.
Well, we have a trip planned with my oldest friend and his wife, and my granddaughter is graduating in the spring.
Okay, that's helpful. So I think it's very likely you'll be able to go on your trip in the fall with your oldest friend, since that's just coming up in the next few months. I even think you'll be able to visit your daughter or granddaughter's graduation, which is even a few more months later. Is this what you were expecting?
I'm just relieved. I guess it is.
I know that talking about these kinds of things can be, well, a little touchy.
You're right.
Do you want me to discuss more, give you more details about this?
Not really, but I might at another time.
Okay. So tell me what you're going to tell your wife about what we talked about today.
That you said I would probably make it to our daughter's graduation.
That's what I said. And we'll discuss this more next time, if you would like.
Thank you.
So that's how something can go for someone who does want to talk about the issue. Now, Marcia's going to help me how a doctor might talk to someone who really doesn't want to talk about this. And Marcia said I picked the wrong woman. So, okay. So, are you interested in us talking about the prognosis for this kind of cancer? Some people want lots of detail, and some people just want the big picture, and others would rather talk about these issues with their family. How about you? How would you like me to talk?
I know you can't tell me exactly how long I have.
Well, that's true. The best I can do is give you information that's based on statistics and averages of other patients, and I know that's not what everyone wants.
Only God knows what's going to happen to me.
It sounds like faith is important to you.
Of course it is. My whole church is praying for me.
Well, it's great to have that kind of support.
I don't know what I'd do without it.
That's very nice. Now, can I check in about something else? I know that statistics are certainly no substitute for God, but sometimes they can be useful for planning. As you think about the future, what concerns you the most?
I'm hoping that this chemo that you've been talking about is going to work.
Are you interested in me telling you about how often the chemo works?
Okay.
It sounds like you're not sure you want to talk about it.
Well, actually I do. But what can you say? Isn't this in God's hands?
I think that talking about the chances that chemo will work doesn't really affect your faith. I think you can have a lot of faith and still benefit from the information that we have, that we know from other patients who've been on this same chemotherapy. Some people find that knowing about what has happened to other people helps them plan.
That makes sense. So, how often does the chemo work?
So the chemo that you're taking works to shrink the tumor in every 4 out of 10 people that take it. That means that 6 out of 10 people that take the chemo, the cancer doesn't shrink. So we'll check your CT scan, and after about 2 months of chemo, we'll see if it's making the tumor get smaller. If it's working and the tumor's smaller, then we'll continue. And if the chemo's not working and the cancer is still growing, then we're in a new situation with different chances. Does that all make sense to you?
You said 4 out of 10 people have their cancer shrink. Is that right?
That is exactly right. Is this anything like you expected?
I'm going to tell my friends at church. I'm worried about this.
I know this information can be hard to hear.
Yes, it's hard, but I'm glad you told me.
Do you have any other questions right now?
No, I don't need more just now.
Can I check in with you next time about these kinds of questions so we can discuss this further?
Certainly.
Thanks. So that was a little bit different, and hopefully what you'll find with your doctors as you approach these kinds of difficult situations is that they'll handle it similarly, that they'll listen, that they'll ask you questions, that they'll try to probe how you want to hear the information, and then we'll be truthful and try to help you actually progress further so that you can still retain many of those hopes, because a lot of those hopes didn't have anything to do with treatment. They didn't have anything to do with prognosis. They had to do with how you want to live your life. And that is a way that the doctor can still help you. So that was all the formal stuff I prepared. So I'm happy to answer any questions.
Yeah, extraordinary. The floor is open. Bill, let me bring a microphone to you.
Is anything like this printed that we could have?
I'm sorry.
Is anything like this printed that we could have?
Well, we could print off the.
Take the last part, about the death and all that.
We can print off all of these slides and certainly make those. And this will be on the website. On the TAB website.
All of these presentations are Dave Stryker's put up on the TAB
And
website.
we can put the actual slides on there as well.
And can-
Yeah. Yeah, that's fine.
So it'll be on the website, and we can also print it off for you if you want.
You have to have a computer for that?
We'll talk offline.
Merv, from the physician's perspective, what's the best way to for a patient to approach the idea of having a second opinion at any stage of the process? And I know everyone's a little bit different, but is that a detriment to the initial physician's feelings toward their patient?
Not in this day and age. It might. So, if you've been going to the same family doctor for 20 years, and you suddenly for the first time come up with something like that, that might be a little bit of a surprise for the doctor, for you to say, I think I want a second opinion. But particularly for referral-based things, like happen to a lot of specialists now, like if you're being referred for a cancer diagnosis and a cancer treatment, people know there's a lot of information out there, and there's a lot of different ways to have it done, and people understand. And so what you need to do when you sit down and you have the talk, you need to have it's always best if you have someone who can come and take notes. So you can ask your questions. Because if you're trying to ask your questions and take notes, it's kind of distracting. So it's better to have someone come who can come and take all the information down so that you can go back and talk about it. And then you don't have to decide there that you're going to go ahead with the treatment. You may wish to say, well, I want to learn a little more about this. You can say you'd like to come back and talk about it again. You can even ask them. So, again, this if you ask them, so who's the biggest authority on this thing? They may say, well, I am. And sometimes it's true. But a lot of times there's other people out there that know a lot more specific information. So another way to ask that same question, to not make it so, is to say, well, I'd like to read more about this. Where can I find specific information about this and the treatment? Because of course that's where you're going to find all the other names of the people as well. And you might find that the best place is going to be in Florida or California. But where is the best place in the world to get treated for testicular cancer? Right here. There's several different cancers that, for a couple of different kinds of breast cancer, you can't find any place better than right here in Indianapolis. For testicular cancer, the same thing's true. If you talk to Larry Einhorn and you said, I want to talk to the best person in the world about this, he could say, well, you're talking to him. And it would be true. But I think that's the way to ask that question is, I need more information. Where can I find good factual information?
So when you were talking about the importance of the physician talking to the patient so that they can get on with their life and determine what they want, one of the things you didn't bring up were the costs involved with a lot of these procedures that happen at the end of life. And that's something I struggle with when I see so frequently these really, like the day of somebody's death, they're doing dialysis, the day they're doing a CAT scan, they're doing all of this, and yet the patient can't really say, I don't want this.
Well, they can.
Well, I know they can, but they just are incapable of doing that, so, for some reason. And so, can you just kind of address some of those things on how to get around that?
Yeah, I actually, I have to say, I encountered this when my wife was being treated. And some of the doctors who were treating her would not talk to me about prognosis. And I wouldn't let it go. I'm sort of like Marcia. I wanted to know everything that there was to know. And I never did get that from some doctors. So what you may have to do is you may have to find a doctor who will talk to you and who will give you the straight scoop on how things are going. And if you really can't get that from the doctor that's treating you, there's absolutely nothing wrong with you looking to find someone else who will and who can effectively communicate. Because it was very disturbing to me, it was very frustrating, and it didn't help us in her treatment. I felt if I hadn't have said anything, she would have been one of those patients who would have been treated all the way to the very end. And the dynamic was because she didn't want me to feel like she was giving up, and even though we talked about that, and I said, no, we need to be real clear about this. I always felt she she was always ready to try anything that anybody offered because she felt like that was her role in this thing we went through. So that's kind of maybe a little more personal than you'd like, but it's the truth. And you need to find someone who will talk with you.
Well, I didn't think about this until the last question, but you do hear a lot about the fact that most people incur 70% of their total health expenses over their lifetime in maybe the last 6 months.
It's true.
And that's very disturbing. But on the other hand, you don't really think, it would be hard to decide. You just don't want, it's a slippery slope there for the patient and the family.
It's an extremely difficult and really there's no good way to answer that. Suddenly, if the nation wants to cut down on healthcare costs, there's one place they'll turn.
Ration it, yeah.
That's exactly right. So, so the easiest way to cut down on healthcare costs is to say, if you're over 55, you don't get a hip replacement. Don't get it. Or you go on a list, and the list is so long that you never do get it. I mean, I can't ever imagine that happening. But that's one way that's one end of that equation. The other end of the equation is, keep going. And I'll tell you something that's coming, and we're only guessing how it's coming, but there's a whole new movement that's coming where at some point in the future the way in which physicians and healthcare groups are reimbursed is going to change. And people will get paid a certain amount of money to take care of a certain amount of people to keep them healthy. Actually, you get paid to keep people healthy, not to paid to take care of people who are sick. So if that changes, then in fact, paying for someone who's in the hospital is actually going to take money away from the system. I mean, that dynamic may come into this at some point going forward. And it's just something to be thinking about, because then that sort of changes the dynamic. Now your doctor doesn't ever want you to go to the hospital. He doesn't want you to have any procedures, right? Because that's the way that system works. So he has to keep you healthy without spending any money. That is something that that may be coming. I'll just put it that way.
Merv, does the kind of litigious nature of things now, does that play a factor in, one, how doctors give you news, and two, this kind of thing here of keeping care going that may seem unnecessary, but they don't want to be in a position to be sued for not completing their mission?
Yeah, actually, that's a very interesting point. On one hand, I would say no, that doesn't play in a role. But on the other hand, the fact of the matter is, it is something that people talk about. So if you're taking care of a particular patient and you've done everything but actually this test, and you know that 99.9% of patients that have had this kind of workup have that test, you'll talk about, well, should we really do that test? Standard of care. Because if everybody else has had all those other tests and this test, and we don't do that test, is that going to be an issue? So on one hand, that can come up, but on the other hand, we're also all trying to reduce healthcare costs. So, and we're trying to reduce stuff that we do to patients. So, you know, for many years in the newborn intensive care unit, everybody got a chest x-ray every morning. Just happened. Because most of our patients were still on the, well, every baby that was on a ventilator got a chest x-ray. And some of them got twice a day, because you sort of needed to know where that tube was that was helping that baby breathe, and we just got x-rays twice a day. And then we actually looked at that practice and actually asked, how many times do we look at those x-rays and change something? And it turned out it wasn't nearly as often as it should have been for what expenses were being incurred, and the fact that we were giving them radiation twice a day, whether they needed it or not. So now, you know, we don't do stuff like that. I mean, thankfully, things are done differently, and so for a lot of tests like that, people are doing less and less and less of testing per se, but still trying to work it into the context of a standard of care. So what is the standard? So the standards of care have to change as we're changing, or it could be something somebody could pursue.
Want to be very cognizant of time, and so will you please join me in thanking Merv for this presentation.